Get away. Well, good evening, everyone. My name is Anita Asgar. I'm an interventional cardiologist from Northwestern, and I'm pleased to introduce my co-moderator, Dr. Jason Rogers from Sacramento UC Davis. And we're here to welcome an amazing panel with us this evening to talk about tricuspid TEER, advanced procedural strategy.
Yes, Anita, this is a very exciting time for tricuspid TEER. Uh, Adoption is rising, and we now have a national coverage decision in the last 24 hours reimbursing this procedure. So this is a great time to tune in and learn some of the best practices from an expert group of speakers that we have listed here. So we will introduce each speaker as we progress through this webinar. Next slide. These are our disclosures. Next. And we do want to acknowledge Abbott, right, Anita?
Absolutely. Without them, we wouldn't have been able to produce the ebook, and they have been very kind to support as well this webinar.
Fantastic. So just to highlight that level of support, we are offering credit for this CME credit, one credit, I think, for this webinar. And I want to highlight these ebooks, which are open access, which means free. There's no cost. Anyone can download these through the SCAI website. And we have the original mitral TEER book and then also the tricuspid TEER book on the right in the lighter blue color, which is featuring now the authors of this ebook are featured in this webinar today. So the people you hear speaking are the people who wrote the chapters in this ebook. So I would encourage you to download this. There's a online version which has moving videos of echoes and other educational videos. And then there's also a PDF download if you just want to look at it on your iPad or iPhone without the moving images.
All right, well, maybe we'll
So
get it going. We're going to start with a case from Dr. Tai Pham at UC Davis in Sacramento, followed by a presentation by Dr. Rhonda Miyasaka on imaging. So, Tai, take it away.
All right, thanks so much, Dr. Rogers, Dr. Askar. I'm going to share my slides here. All right, can you guys see it here?
We can.
All right, perfect.
yes.
So case today is about a 73-year-old woman who was referred to us for evaluation of TR. She has a known history of reduced EF heart failure secondary to non-ischemic cardiomyopathy. She had a BiV device placed several years ago with now recovered ejection fraction. And she also has pulmonary hypertension as well as paroxysmal atrial fibrillation on warfarin, hypertension, and CKD3. She came to us with class 3 heart failure symptoms, in addition to worsening lower extremity edema, as well as intermittent nocturnal dyspnea. And here are her medications. She's on Coreg, aldactone, warfarin, and Lasix 40 daily. And unfortunately, despite further attempts at increasing her diuretic dosing by her referring cardiologist, her symptoms persisted and she developed worsening CKD. So they had to sort of back off on that a little bit. On exam, she's V-paced, heart rate's in the 60s, mildly hypertensive. Her creatinine is elevated, but that is at her baseline, and she's got an elevated NT-proBNP of 2200 and a therapeutic INR. And here's her screening transthoracic echo in the RV outflow view with and without color. You can see severe coaptation gaps as well as torrential TR. Gaps measure about 11 to 12 millimeters on some of the views here. And then this is the RV inflow view with the Nyquist limit turned down a bit. And then here's your apical 4-chamber view with the modified RV image. Here you can see a severely dilated right atrium and a really large regurgitant area. And as with all of our patients, we do a screening right heart cath, and here you can see she has an elevated right atrial pressure mean of 14 with significant V waves to 30 and a very ventricularized RA tracing. She has mild pulmonary hypertension with a mean of 26, and fortunately, a wedge of only 18, suggesting that most of her symptomatology is predominantly right-sided. Her index by both FIC and thermodilution are low from 1.1 to 1.3 respectively. And so the big questions for us are, what do we do next? Do we proceed with the screening transesophageal echo in her current state? Do we proceed with TriClip with intraprocedural TEE? Is her anatomy prohibitive for TEER? So do we evaluate her for TTVR? Do we admit her for prehab and reevaluate with a repeat echo when she's more optimized? Or do we offer her nothing and just continue her current medical therapy? And so I'll leave that there and we'll revisit this case towards the end of this webinar, and I'll kind of hand it back to Dr. Rogers and Dr. Askar.
Okay, that was a great case highlighting some of the anatomic challenges. We had pretty large gaps there. So I think I wanted everyone, and we want everyone to keep these options in mind as we listen to the speakers, and then hopefully people can formulate their own decision, and then you'll show us what you did at the end.
Sure.
So great. Anita, we have our next speaker.
Yeah, so I'm going to introduce Rhonda Miyasaka. She's an imaging interventional imager from the Cleveland Clinic and also our co-editor for the Tricuspid TEER ebook.
Hi, Anita. Hi, Jason. Thanks for including me on this. It's great to see everyone here tonight. And Ty, that was a great case to start us off. I am going to share my slides here. Okay. Can you guys see my slides okay?
Yes.
Okay, perfect. So I'm going to be talking about TE imaging and really trying to focus on, what techniques we can use to understand tricuspid anatomy for the purpose of tricuspid TEER. I think everyone is familiar with, our standard TE views that we need for tricuspid evaluation. We need a long axis view that lays out the valve and shows us our septal and lateral leaflets. This is going to be our grasping view. It tells us what our leaflet lengths are, what our coaptation gaps are, the subvalvular apparatus, our TR mechanism. We need a commissural view that lays out the valve from anterior to posterior. This tells us where our TR origin is. If the jet is focal or broad, tells us the location of device leads. And then we've got our short axis view that tells us our tricuspid morphology, the number of leaflets, where our commissures are, coaptation gaps, TR location, and leads. And so whenever we're doing our tricuspid evaluation, these are the views that we always want to make sure that we have to understand our tricuspid anatomy. Anyone who knows me, though, knows that I love working in 3D imaging. And that's because switching back and forth between multiple imaging windows can be time consuming, and it also can introduce the possibility of error or off-axis imaging. And so I use a lot of 3D multiplanar reconstruction. We get 4 views for the price of 1. We get our septal lateral view, an anterior posterior view, our short axis view, and then our 3D on phos view. And by turning color on and off, we can really get a good sense of where the TR is and what the mechanism is. But the first question everyone always asks me is, well, I have trouble with my 3D imaging. I go into 3D, the images aren't quite good enough, so I have to go back to 2D. And so the first thing that I'm going to quickly touch on is what we can do for TE image optimization. Really, the most important thing to understand is that our 2D image is completely, our 3D image is completely dependent on the quality of our 2D image. And so the first thing we have to do before going to 3D is really spend time optimizing our 2D image. So here's an example of a patient whose mid-esophageal view has some shadowing. And so our 3D imaging has some shadowing. When we go to the deep esophageal imaging window, you see that we have a little bit better image. We start to see a tricuspid anatomy better on our 3D image. When we then go to a deep esophageal view and we use our lateral knob to really get a high quality 2D image, that's where we're finally able to bring out a really high quality 3D image where we can understand anatomy. The other point that's really important is that 3D imaging is not going to fix bad 2D imaging. If you have a bad 2D image, your 3D image is going to be 10 times worse. This was a trick that Anita taught me that we use all the time now. If you're imaging the patient's supine and you're getting a lot of shadowing, if you put a pressure bag under the right shoulder, tilt the patient onto their left side, kind of simulate, what your positioning is in the TE lab, that can help you optimize your 2D image, and that can also help optimize your 3D image. And then also we pay attention to fluoro. So intraprocedurally, if you're noticing that you really can't see the device very well, sometimes it turns out that you're imaging exactly through the delivery system or the device itself, and that might be an opportunity to move the probe up or advance it further and flex. And you can see here, this helped us optimize our imaging window to see the TriClip again. Once we have a good 2D image, the next step is to move on with our pre-procedural evaluation. And so what I love about 3D MPR is that it really allows us to bridge the gap between pre-procedural imaging and intra-procedural guidance. So if I'm looking at this tricuspid valve and I want to know, can I put a TriClip device in this location with this orientation across the septal and anterior leaflets? It's very easy to do that using 3D MPR. We just align our grasping plane in the exact location and orientation as how we would visualize our clip. And then we can evaluate that grasping view for the grasping condition. So we can look at leaflet length, coaptation gap, subvalvular apparatus, the presence of leads. It makes things very straightforward for us. And the next thing we can do is actually evaluate, try to predict potential challenges. So one of the reasons I really liked your case, Ty, is that I chose two things to focus on this talk, and that was gaps and leads. And it looks like your case has both of these things, gaps and leads. So that was a very nice setup here. We know that when we image a gap using 2D imaging, we can use a gastric short axis view, we can use esophageal long axis views. The problem when you're using 2D imaging alone is that you don't really know if you're imaging at the leaflet tips, you don't know if you're imaging in the exact location or orientation where you'd be placing a clip. And so it's hard to know if this accurately represents the grasping conditions. Biplane imaging can help us understand where we are, but it just doesn't provide us as much precision as what we can accomplish with 3D imaging. And so here's an example of a patient who has a large central coaptation gap. You'll see initially in that upper left image, we have a very large coaptation gap. But if you look at my imaging plane, I'm imaging, straight across the middle of the valve in that AP, commissure. And that's not where we would ever place a clip. We wouldn't place it straight across the valve like that. And so what we can do with MPR is we can actually adjust and evaluate different imaging, views to look at a septal anterior grasp or septal posterior grasp to get a better sense of, what's doable. Leads are another potential challenging, can be difficult to understand where the lead is, if it's interfering with the leaflet, if it's causing TR. This is an example of a patient that was actually referred to us for lead extraction because it was felt that the lead might be impinging the posterior leaflet. And when we did 3D imaging of this lead, we could see that the lead was actually tucked in really nicely in the septal posterior commissure. All of the TR is anterior and central to the lead. And so if we just move our grasping plane into a septal anterior grasp, it turns out that this anatomy was actually very nice for tricuspid TEER. That's unlike this patient who we evaluated for TEER, who had a lead again in the gastric short axis image. This lead looks like it's in the middle of the valve with TEER across the coaptation zone. When we go into 3D images so that we can get a long axis image at the same time as the short axis, you can see that the lead is actually inserted into what looks like the pap muscle, and the leaflets are, fibrotic and thickened and restricted. And then when we turned on color, we could see that all of the TR was actually posterior and lateral to the lead. So this, was anatomy that we felt would be very difficult to treat with tricuspid clip. Next, moving on to intraprocedural guidance. We rely very heavily on MPR for our procedural guidance from start to finish. This is a case that we did recently. The one anatomical feature I'd like to point out is that the septal leaflet has what looks like two segments to it. You can see the red arrow showing a commissure between two segments of the septal. And so for that reason, when we were planning our grasp, we countered that green plane just so that we could go from that more posterior aspect of the septal leaflet across to the anterior leaflet. And we can see the TR is in the center of this valve. We start out by advancing the clip into the right atrium. We use MPR guidance to stay aligned on the clip as we bend down towards the tricuspid valve. And we eventually line up the clip in our septal anterior grasping view. And then once we cross the valve, we continuously monitor the clip position and trajectory. So I know a lot of people during grasping will move down to a gastric image to make sure that there haven't been changes in the clip's location or the orientation. You can see here, if you look at our short axis image, when we crossed the valve, the clip actually moved posterior. And so now we're grasping in the AP commissure, not anywhere where we would want to be doing a grasp. But because we could notice that on our short axis image, we were able to bring the device more anteriorly again and proceed with grasping with a septal anterior grasp here and reduction in TR. We always, in addition to 3D imaging, we confirm our grasp with 2D biplane imaging and gastric imaging as well. Multiple views. As much as I love 3D imaging, I'm always confirming with gastric views and esophageal views as well to make sure that we have as much information as possible. We ended up releasing this device and just ended up using just one clip for this particular patient. So in summary, I think 3D MPR is a really powerful tool. It's a universal language. We can use it with esophageal images, gastric images, and also 3D ICE. The formula is always the same. You're going to have a grasping view, a short axis view, a commissural view, a 3D on FOSS. And you can use that to simplify understanding of the anatomy and predict procedural challenges, and then use MPR for continuous monitoring of the device intraprocedurally as well. So that's what I have for you guys. Thanks for your attention.
That was great, Rhonda. So I asked some imagers once, so if, you know, like LAA imaging is like a 3 out of 10 difficulty and MitraClip is maybe 4 or 5, I mean, and then tricuspid is,
TriClip is like a 50 out of 10 with the difficulty.
Wow. Wow. I was going to say 11, but yeah, so it's, I mean, realistically, I mean, as people, because most of the people on the webinar are going to be doing M-TEER. I mean, what are sort of your top 3, you know, formula for success in transitioning from mitral to tricuspid for the imagers?
I think that, you know, TriClip is challenging. Imaging is challenging for 2 reasons. It's challenging because the actual image acquisition, it's harder to see the tricuspid valve because it's farther away. And we have to use more knobs and we have to use different imaging windows, you know, like gastric views. And so the actual imaging is more difficult. But on top of the imaging being more difficult, the anatomy is much more difficult because every tricuspid valve is so different, you know, gaps, leads, and so forth. And so I think things that help, you know, people as they embark on, you know, moving from mitral imaging to tricuspid imaging is really when you're doing mitral imaging, starting to use 3D more, starting to use 3D MPR more, even using, you know, 3D MPR from gastric images of the mitral valve, just because the mitral valve anatomically tends not to be as complex. So if you get comfortable doing these different imaging techniques on the mitral valve, it's much easier to apply to the tricuspid valve. And, you know, I think the other thing that's really important with tricuspid imaging is just evaluating all of your imaging windows at the start of the case. So the first thing that I'll do with, you know, whether it's a screening T or, you know, intraprocedural, is you're going to look at your mid-esophageal, your deep esophageal, your gastric, your deep gastric. You're going to try to figure out, you know, what your options are. Even if you have good imaging at the start of the case, you know, once the TriClip system is in the right atrium, all of the imaging can change. And so having that flexibility, I think, is really important. And then the last thing I'll say to all of the interventionalists is, you know, give your imagers time to really optimize the image because it can be challenging. And so if you have time to, you know, optimize the imaging at the start of the case, that can, you know, help throughout the case. I think those are the top things that I would focus on.
Great.
That's great, Rhonda. Thank you very much. It's my pleasure to introduce our next speaker, Dr. Matthew Price from Scripps, who's going to talk to us about leaflet grasping, techniques, pitfalls, and how to avoid SLDA. You're on mute.
Can't hear you.
There we go. You can hear me and see me now, correct?
Yes, we can.
Yes.
Thank you. All right. So
Good look.
this talk will really resonate and sync with the presentations that I've gone before. So we're going to talk some fundamentals of grasping, assuring that you have good leaflet insertion, and how to avoid SLDA. So let's set the stage. We've got our clip into the right atrium. We have flex down to the tricuspid annulus. So the key thing when we begin the grasp is to make sure that our position and trajectory is appropriate over the tricuspid valve. And let's just, again, go to the fundamentals. You have your X-plane view here. You're either mid or deep esophageal X-plane. And you have on the left-hand side of the screen, you will you will see you have the posterior aspect of the valve and the anterior aspect of the valve. And then your explaining of the RV outflow, and you see here that this leaflet will be the septal leaflet, and the lateral leaflet will either be the anterior or posterior leaflet, depending on where you are on the tricuspid valve annulus. The key is to make sure that your shaft of the clip is perpendicular to the annular plane on both the RV inflow and outflow views. So when we think about the different knobs, if we felt our trajectory was not appropriate, let's say we are pointing more towards the anterior aspect, we'd add F knob, and that will move us angle more towards the posterior. Or you could reduce the F knob, and that would lean you more anterior. Now, this is really important for grasping because it's really the setup of the grasp will make the actual grasp easiest and best. So here on the other side, you're going to be wanting to go like this, straight up and down. This looks like a really good trajectory, but if we felt like we needed to be a little more septal, we would clockwise rotate the steerable guide catheter. And if we wanted to be a little more towards the anterior posterior leaflet, we could counterclock the guide to go in that direction. Now, something that's really going to help you when you are grasping is if you have this thing called the septal hugger, is to understand the SL knob, which is new from the MitraClip system. So a septal hugger is when in the RV outflow view, when your device is going from septal to either anterior posterior to the lateral leaflet. So you see here, you want to be straight up and down like this, but we're coming across from the septal. This is a septal hugger. This is when we're going to use the L knob, and we would add L knob, and then we would take off a little flex and clockwise rotate, and we'd be straight back up and down. This is the trajectory we want. So this L knob is going to be a real unlock for grasping with the TriClip when you have a septal hugger. So please remember that. The other unlock is going to understand the use of independent gripping or controlled gripper actuation, CGA. So remember that the grippers are independent of one another. And when before we do our grasp, before we cross the leaflets, you're going to orient yourself. You're going to have this view where you see the arms wide open. You will unlock this lever and drop the gripper with the tactile marker, this little bump here, and you will look and see, is the gripper coming down on the septal leaflet or the anterior posterior leaflet? And once you identify that, you remember it or mark it down, and then you press the other one just to make sure that the other gripper works. So you've oriented the grippers when you need to use CGA for leaflet optimization, which we'll talk about. The other thing is to make sure that you are orthogonal to the plane of the leaflet coaptation. We do this orientation almost always in the transgastric or an MPR view. And now we're above the leaflets. Our arms are open. We like our trajectory. But you see here, if I'm going for the septal anterior leaflets, I want my clip to be slightly clockwise rotated. So what you do there is you clockwise rotate the handle. That will bring the entire system septally because clockwise rotation brings you septally. So you'll have to counterclock the guide to get back to where you need to be. In contradistinction, if you are too clocked, here I want to counterclock the clip. So I will counterclockwise rotate the CDS handle, and at the same time or soon afterwards, clockwise rotate the steerable guide, and you will orient appropriately. So that we now have trajectory, position, and you've oriented correctly over the valve. So how do we approach this? This is from the TEER ebook, which hopefully you all will download and read. The key thing is first to make sure that you're perpendicular to the plane of coaptation. Then our first approach is going to be simultaneous grasping. We'll talk about that. We will check and confirm insertion. And if we don't like insertion, we will optimize using independent leaflet grasping or CGA. All right, here's an example of this. So we have now advanced this clip across the valve, and I generally advance in the inflow outflow view, and then we go to transgastric, or you could be an MPR, and we're looking at the orientation of the clip. We've liked that. So once our arms are open and we then orient for the grasp. And here we are. And also a key thing is not to do much of the knobs or rotation while you're underneath the clip. So underneath the leaflets, excuse me. So what's different now from the last pictures, we've advanced and we're ready for a grasp. All right, so how do we grasp? And Rhonda sort of talked about this a little bit. There are multiple different views where you can establish your grasping images. The go-to is going to be your RV inflow outflow. You can see here, you can see very nicely my grippers coming down in a simultaneous grasp. Some people like to grasp the transgastric short axis. You're going to really have to confirm leaflet insertion if you do that. If you have problems, you can do live NPR, either mid or deep esophageal or even transgastric. And finally, the bailout is 3D ICE live NPR. So you have some options to you, but generally it's recommended when you're beginning to use the inflow-outflow view. Once you have dropped your grippers, closed your clip, go to 60, lock your clip, close all the way or almost all the way, you can then check for insertion. So there's not one view we check for insertion, we check in multiple views. The transgastric really gives you I think a really nice view of insertion. And the key is something that Burkhard Mackensen coined, is this bouquet of flowers, where you see your clip here, grasping the leaflets, bringing them together. And I guess these are your flowers here. What's going to be really key, these are both different SA grasps. I think this is a nice picture here of a grasp. You don't really do a single clip in the middle, kind of odd, but what you can see really nicely here is, how do I know I have a good grasp? Is the leaflets are going into the center of the clip and around. These leaflets, the tissue bridge is draping over the entire arm on both sides. I do not have these leaflets by the fingernails. I have a nice solid grasp. You want to also confirm in multiple views. These are other examples. This is an inflow-outflow view, mid or deep esophageal. Generally, we don't use color, but we're looking here at the length and how mobile the leaflets are. And if all else fails, you can use ICE to see very nicely your grasp, your leaflet insertion, excuse me. So it's important. There are 4 things you need to look at when you're looking at insertion: reduced or minimal leaflet motion, leaflets draped over the arms, a shortened leaflet length outside of the arms, and a wide tissue bridge on the transgastric short axis. Just quickly about optimization. So if you're ever worried or concerned that you don't have enough tissue, you need to do leaflet optimization. So in this particular case, I mean, look at this. It seems like I have enough septal leaflet. It's short and immobile, but I wanted a little bit more. So I opened up my arms. I raised the septal gripper. I advanced the clip system, I advanced the handle just a little bit, clocked the guide gently, and then re-drop the septal gripper and close slowly. And you see here, although this is a color image, so not that resolution isn't the greatest, you see I do have a bit more septal leaflet now than I did before. So small movements with control gripper actuation will help you optimize. And when in doubt, optimize. So key points then, you need to ensure your clip trajectory is perpendicular to the leaflet cooptation. You do that generally in the X-plane RV inflow outflow. And remember that SL knob, it's the unlock for septal huggers. Make certain that your clip orientation is orthogonal to the leaflet cooptation plane at the site of the intended grasp. Really, transgastric short axis is your friend, and you're still above the leaflets at that point. You then close the arms, cross the leaflets, open up the arms, and reconfirm orientation. And when you do your grasp, have a low threshold to use control gripper actuation to raise the individual grippers, look at your insertion, and optimize it. And finally, confirm insertion in multiple views. Multiple views. The 4 key things are minimal and reduced leaflet motion, leaflets draped over the clip arms, a wide tissue bridge in the transgastric short axis, and shortened leaflet lengths. And use as many images as you need. And with that, I will leave it at that. Thank you, Anita.
Thank you, Matthew. That was a great overview of best practices, really being precise with trajectory alignment. We're going to have some overlap, I think, with Paul's talk later on avoiding SLDA. In the interest of time, we'll move on to the next speaker and save discussion, I think, for after Paul's talk. So it's my pleasure to introduce Atushi Sugiura. whom I believe has worked with Georg Nickenig together, and obviously a great center there. And Dr. Seguera, you are going to tell us about multi-clip strategy for complex TR. Thank you so much for joining today.
Yeah, thank you very much for having me on this topic. And do you hear me and do you see my slide, right? Okay,
yes,
and
yes,
I
we
move
see
to
it.
my topic. Yeah, great. Okay, great. Thank you very much. I'm currently in Japan, so good morning to everyone. Some disclosure. So my topic is all about the use of multi-clip strategy for complex TEER, because it's quite often if you are doing a transcatheter H2H repair for tricuspid regurg. So first to ask is where to start, where do we start, and also how many clips and where is the really important question for the beginning. And we ask ourselves also, what is the optimal clip length and width, which is normally XT or XTW devices of tri-clip, and where is the coaptation defect and TEER jet coming from, and also what is the coaptation gap with, how large the coaptation gap is, and is there pacemaker reads, and how the leaflet configuration, sometimes not only 3, but also 4 or 5 leaflet configuration. In this case, you can see on the left-hand side, we chose TriClip G4 XTW system, and TEER jet was coming from not only central, but also anterior septal to posterior septal commissure, large coaptation gap width, and no pacemaker read, and thanks to God's 3 leaflet configuration, there seems enough leaflet tissue to grasp. And the really key question is where to start. I know we are always preferring doing anterior septal clipping, but where in anterior septal commissure? We need to ask the location of the first device should be decided to balance between addressing the central coaptation gap as much as possible, and also by mitigating the risk of residual TEER from anterior. And also we have to keep in mind that the nearer it comes to the anterior papillary muscle, the more tension or more tethering effect on the cord. So that's why in case with a large coaptation gap, we prefer to place the first device in the anterior septal commissure at the level of anterior scallop, and then add the second clip, which may be an effective strategy for treating TEER, and also might reduce the risk of single leaflet device attachment afterward. First key point is confirming optimal leaflet grasping. The first device is very important, so we need to check the leaflet insertion as pointed by the current speaker, and the TEER reduction. Do we have TEER reduction, and also do we have residual TEER from anterior or not? If we are happy with the first device, then still you have a residual TEER from posterior to the first device, then it's time point to go to multi clipping. The question is the location of multi clipping, which depends pretty much on the leaflet morphology and coaptation gap width and the TEER jet location, namely jipping or clover technique. And check for anatomically, so we need to check the location of severity of residual TEER, and also remaining coaptation gap. Of course, we need to check the morphology of tricuspid valve. As you see here, the anterior and posterior leaflet, septal leaflet, and also we need to see the risk of tricuspid valve stenosis after much clipping. So briefly, zipping versus clover. Zipping, I think it's simple to grasp, and even though we still focusing on anterior septal commissure, but still we will have further remodification, and which make address central TEER, but also posterior septal commissure, and also facilitate throat clipping. But we need to keep in mind it may result in relevant residual TEER in posterior septal commissure. On the other hand, crowbar technique, which is practical, especially if TEER jet predominant in posterior septal commissure, you will have good annular remodification, but we also keep in mind that the posterior leaflet is often split. And if you have too large gap in posterior septal commissure, and the grasping might not be optimal. And clocking is also important. Operator may have to intentionally rotate the clip arm, thereby pulling the grasp leaflet towards the anterior or posterior, depending on the location and morphology of the leaflet. So there's the remaining coaptation gap and in the central. So we place the second device, then the third device at the posterior septal commissure, and ended up like this result. So this is the conclusion. So I would summarize just 3 points. Confirming optimal leaflet grasping and the TEER reduction through the first device is the first step for the multi-clipping, and the location of multi-clipping depends pretty much on the leaflet morphology and coaptation gap width and TEER jet location. And clocking really important and may need minor adjustment, not always perpendicular to coaptation line. Thank you very much.
Thank you so much for that talk. I noticed when I was at New York Valves, it was interesting. It seemed like the Europeans were much more promoting the Clover technique. They've had some series on that and looking at outcomes, which may be a little better. Hard to say because there's selection bias to who you Clover, who you zip, and then here in North America, it's much more focused, I think, on zipping technique, really sticking with the anteroseptal. So maybe, I mean, Guggen, can you comment a little bit on your experience with those two techniques?
Yeah, I mean, again, that was a fantastic talk, talking about the clip strategy. I think the part of the issue is that with Clover technique, you're predominantly thinking about it in not just 3 leaflet tricuspid valves. Usually it's 4 or 5, and you're basically trying to create coaptation. And I find the Clover technique in that scenario is, while it's doable and we see the great cases, what we don't see is the cases that don't go well with the Clover technique. Whereas a zipping technique, just I think the anatomy tends itself to really bring in that annulus and create more of a reproducible and a scalable TR reduction. So I think in our experience, in my own personal experience, I find the Clover technique to be a little bit more unpredictable in terms of if you're going to have acute and durable TR reduction. The zipping technique seems to do more. And actually, Philip Lurs was doing a live case at New York Valves. For sure, I thought he was going to do a Clover technique, and all of a sudden he ended up zipping. So I think that paradigm is changing a little bit about this Clover technique as the primary approach. I think it's shifting a little bit towards going back towards zipping.
Yeah, I mean, is there a reason you can't just zip and then Clover? I mean, do them both? Are you worried about gradient at that point, or?
Yeah, I mean, I think the Clover technique allows you to kind of bring in the AS and the SP. I think it's probably works best for when you have, as was mentioned, kind of these larger gaps in the SP segment. It does require a lot more CGA work and to be able to do a true Clover. And I think that's fraught for additional complications such as leaflet injury as well. So, and then you have issues with gradients as well, like you mentioned. So you're often thinking about, if you're zipping and then doing a Clover, now you're thinking about putting in 3rd clip on, 4th clip on. And I think that's where you will get into trouble with gradients.
Great. So we're going to move on, and Guggen's going to lead us into our next presentation, which is ICE imaging for procedural guidance, when and how to use.
Great. So if you guys don't see slides, let me know, but I think they should be up there.
We see them.
Great. So let's kind of get into it and talk a little bit about, I mean, again, Rhonda and then the others have done a phenomenal job talking about, the imaging toolbox, right? So this is a slide I've stolen from Dr. Rahman, who kind of does the vast majority of imaging for tricuspid at our location. I've learned a lot from him regarding this toolbox, right? And I think Matthew tried highlighting this a little bit too, which is we are not prescriptive in what we are using towards assessing leaflet insertion, to doing trajectory, to deploying the clip. We use whatever the patient gives us. and whatever tools that you have access to. And it could be mid-esophagus, could be transgastric, but all of this is predicated on the fact that you have to have high quality windows. And Rhonda, it's never the imager, right? It's just the imaging windows. So you have to have really high quality imaging windows, not just here, like in these examples where there's no device in place, but when the device is in there, when you have the clip delivery system, when you have the guide catheter, all of them in there, it's incredibly important to have good windows. And so when it all works, you start off like this. You bring your device in an X-planar NPR. You again, using X-planar NPR, you're going to advance into the ventricle. Now, Rhonda may not agree with us, but I still find a lot of value in at least confirming the transgastric alignment one more time. We have been fooled with NPR. Maybe we just need to learn a little bit more. But really the transgastric confirms. And then here you kind of go back and forth sometimes. But for the vast majority of times, you could either grasp in transgastric, as Matthew talked about, or you go back to mid-esophageal, build your NPRs and do your grasp. You do your leaflet insertion assessment, and you deploy. Now, again, that's when it all works well. But when it kind of works, like you're having issues with trajectory, grasping, you're not really happy, you could evert, come back, and then start all over. And then you can see how people can fall into this vicious cycle of starting off in the esophagus and going transgastric, esophagus, transgastric, going back and forth. And when things are really tough and you're really having tough imaging windows and you can't really see anything, you fall into this very vicious cycle of just going back and forth, back and forth, back and forth. And so the role for 3D ICE is really as follows. You can either use it routinely, and I'll kind of show you what that workflow looks like, or use it as an adjunct, and probably adjunctive is not even the right word. It's maybe an as needed. And we'll talk about what that looks like. And so here's kind of the workflow that I think some centers across the United States have adopted, which is if it's going to be part of your regular workflow, this is what happens. You kind of do your trajectory and your alignment, you do it with your TE, you advance into the ventricle, you open up your arms, you bring your probe into your transesophageal probe into the stomach, and you confirm your alignment and you leave it there. You leave it there, you have your 3D ICE catheter in the RA, and then you do your grasp, you do your leaflet insertion assessment, and then only at one time do you pull back the TE probe back into the esophagus, and then you deploy. And so this is kind of what in that scenario, the fluoro image looks like. And I'll just kind of, just to lay the land here for everybody. Here's the prior M-TEER. This is a case where I put in an XTW, and then this is an XT going in. But notice the TE probe stays in the stomach. You don't have to go back and forth. And then 3D ICE catheter is really what's helping guide the grasping. Now, if you are going to use it routinely, there is an added cost of about $4,000 per catheter. So you have to kind of take that into consideration. And for some health systems, I think it's totally reasonable. It can increase case efficiency. You have a lot more confidence in your grasp, but we do lack data. There is a lot of efforts now being underway to provide some additional clinical data on how 3D ICE can help reduce your rates of SLDA and improve visualization and improve confidence, and also improve case efficiency. But what about for adjunctive use? And so here's a case that'll kind of highlight how we use it for an as needed basis. So on every case, we have two femoral venous access sites. We have, and usually I do ipsilateral, others do contralateral. I think either approach is reasonable, but I'll have over the mid-femoral vein, mid-femoral head, in the femoral vein, I'll have my access for the TriClip system. And then about a centimeter below it, I'll have access for the ICE if I need to upsize to a 10 French sheath. So here's our case. You see the patient with significant tricuspid regurgitation with and without color here on these 2D images. And of course, we have phenomenal 3D NPR images. And so again, I can see my inflow view on the left here. This is the grasping view, a very high spatial resolution of that septal leaflet, the anterior leaflet as well. I have a really nice 3D NPR, and so then of course I like to see transgastric. So I'm like, hey, I'm seeing this transgastric, and so I usually tell Idris, I'll wait for you to make it better, and is there anything you can do? And he says, nope, I'm getting a lot of resistance. And so this was the extent of our transgastric view for this particular patient. So now we're walking into a case where mid-esophageal windows are okay, but transgastric windows are more than suboptimal, or less than suboptimal, or less than optimal, I should say. But we have a good 3D NPR, so we should be able to proceed. So here's our trajectory. We're happy with our alignment. We advanced it into the ventricle. So now we have this scenario. In this case, we've advanced into the ventricle. We've opened our arms. And now with the 3D NPR, I'm going to do my grasp. I'm going to do my leaflet insertion. I'm going to deploy. this is the situation now. The clip is in and I'm trying to grab 1, 2, 3, 4, 5 different attempts. And again, we don't have time to go through every single one of them, but we were never really confident in the grasp here. So never really confident about leaflet insertion. So wasn't totally happy. So this is where 3D ICE can come in as needed, where if you have difficulty with your windows, whether it's transgastric or mid-esophagus, you easily advance your 3D ICE catheter in to do your grasp and insertion assessment. Now, the question always is, and what people struggle with is, how do I know when I bring the 3D ICE catheter in, where do I position it? What do I do with my omniplanes? How do I find that one particular omniplane that will help me understand what the arms are? And so what you do is with your transesophageal echo, you confirm your trajectory is good. With your transesophageal echo, you confirm that your alignment is good. And now you use the 3D ICE to determine what your angle is going to be. And you do this concept of a 3D navigation and a 3D map, I guess, if you will. So these are all 3D ICE images. These are all 3D ICE planes. And what you're seeing here is that we've positioned the ICE catheter, and the ICE catheter is actually looking straight down where these lines intersect. So this is the red plane, which corresponds to plus 45. This is the green plane, which corresponds to negative 45. But notice how this is not directly on the clip right now. And so slowly with the same maneuvers that you would do with the tri-clip system, you advance the ICE catheter in until those crosshairs are now positioned directly over the clip. So this is how you physically move the ICE catheter in a more reliable way, rather than just doing a little plug and play, trying to figure out and then playing with the omniplanes. And so now we know that this is negative 45, that's positive 45. And notice how the clip is just a little bit at an angle that's going to be slightly higher than plus 45. So rather than maneuvering your ICE catheter any further, once you get it close enough, look at that. We've turned the MPR, or the 3D navigation feature off, or the 3D map off. We've gone immediately to plus 50, and I can see my arms and I can see the leaflets. And basically what it was the septal leaflet was very long. I wasn't going deep enough. So now I've advanced it in a little bit deeper. I've come back, I've engaged both the leaflets, and now I've started to close the clip arms. And now as a result of that, what we've gone is just with one clip alone, with one XTW, we've reduced the amount of tricuspid regurgitation, but we're not done. With the second clip, kind of the same thing. I build my 3D navigation map. I'm not even going to try to grab in mid-esophageal 3D MPR. I'm just going to do 3D ICE. Now, again, notice my crosshairs. They're directly on top of the arms. In this case, I don't need to go to 40. I stay at 45, and I have excellent visualization of the arms, the leaflets, the grippers come down. And here in panel 8, you can see I've started to close the arms. And so we've gone from a patient who had 5+ TR all the way down to trace to 1+ TR. And again, this could not have been completed without 3D ICE because our imaging windows were suboptimal. So I'll close with this here, which is, I think there's a lot of debate about this, and the standard of care is relatively wide here. Is it obligatory in every case? I think there are some health systems and very experienced operators that have shifted towards that. And I think that's fine for your health system if you can absorb the added cost. There currently is not reimbursement for 3D ICE, but there are efforts underway to see if that can happen. I think for most centers out there, I think its uses in cases where some of the windows are suboptimal. How to determine exactly what omniplane you need to go to, that's what this whole concept of 3D navigation is. And the concept of 3D navigation is somewhat convoluted, but again, the basic premise is that you are using a 3D image to determine what your angle needs to be to find the arms and find the leaflets, as long as everything's been done by TE already. And this requires practice. All the manufacturers have done a remarkable job developing very high quality simulators where you can practice these things. So please do so. And of course, try it out in your normal cases where you have excellent mid-esophageal and transgastric windows, and you can try it out as a team. So thank you.
Thank you, Gagan. That was incredible. Maybe just a quick question for some of the operators, perhaps, that are watching our webinar. How would you suggest you start to use, ICE? For those of them who don't have maybe a lot of experience, can you give us some suggestions on how you would start to slowly incorporate this? Because if we just pull it out when the cases are difficult, it may be even more challenging. Do you have any thoughts?
For me or for others?
Yeah. For other people, again, how would you recommend that a new operator who's doing TEER, when should they think about this?
Paul, why don't you tell us how you use ICE?
So,
how you got started.
I was resistant. I've been doing TEER and TTVR for a long time, and real men used TE, and ICE was for, you know, well-off centers. I've completely come around. I think that the use of ICE has made good cases go quickly and tough cases doable. And honestly, I'm going to talk about it a little bit. I use ICE 100% of the time now, and I found that we can do up to 4 TriClips a day in one room. You may only need it for like a crucial insertion grasp, but it gives an incredible sense of confidence and that the clip is where you want it. So I've completely Guggen has won me over entirely, and I'm using it all the time now.
Great. It's definitely a learning curve. I mean, it helps if you start with 2D ICE doing PFOs, ASDs before you engage the 3D. The way you hold the catheter is totally different. It's literally millimeter adjustments versus TE, which is much greater. So, I mean, tiny adjustments, getting used to that feel. And then the knobs also just they're literally micro adjustments. So those are all things that require time and experience to become facile at. Why don't we go ahead to the next presentation and last formal before we have the case wrap up from Dr. Pham. So this is Dr. Paul Mahoney, Director of Structural Heart Programs in Greenville, North Carolina at Eastern Carolina University. And he's going to talk about potential complications of TEER and how to manage it.
All right. If you can't see my slides, let me know, and I'll try to go through it quickly. A lot of this has been covered by some of our previous outstanding speakers. So complications, how to avoid and how to treat. So, and again, this is all from the book chapter, so all these charts and images are available. So the major complications of tricuspid TEER are chordal interaction and entrapment, SLDA, and those are grouped. And then the less common ones, device embolization, interaction with leads, conduction disturbances, bleeding, tamponade, and conversion to open surgery and cardiovascular death. When we look at the data from the 2 large registries from TRILUMINATE and BRIGHT, we see that mortality is exceedingly low, MIs don't happen, stroke is very low. The 2 major things, SLDA is a size 7.5% in the TRILUMINATE. It's coming down in the BRIGHT registry. Pacemakers are not a problem, and major bleeding with large bore access remains a problem. I'm going to focus on 2 things, chordal entrapment and SLDA, in the interest of time. And I think they are somewhat related. So chordal entrapment, the key steps to mitigate the risk of chordal entrapment. And we had some really good talks on both TEE and 3D ICE to optimize alignment above the valve in the atrium and NPR views to minimize the need for subvalvular rotation. You can see in the illustration here, the chords are very fine. And really in the tricuspid side, you don't have the same tactile feedback that a lot of us have come to rely on with the mitral plane, where you can get a little bit more feeling. Cross the valve plane in a closed position. Use fluoroscopy as an adjunct to detect rotation and correct before opening the clip. And once your clip is open, to minimize the subvalvular manipulation, low threshold to avert and return to the atrium if excessive rotation is present. Okay. Okay, let me see if I can advance it. There we go. So for chordal entrapment, be a carpenter, measure twice and cut once. Just like Rhonda showed you to beautifully line it up exactly how you want it, make sure you're where you think you are before you deploy it. And we do love the transgastric short axis view to go ahead and make sure that you're lined up where you want to be and you don't have any, that your angle is orthogonal to the plane of the commissural alignment. So you didn't do what you were supposed to do, or things got a little hairy and you've got chordal entrapment. Sometimes you have to let go. All right. It can happen with MitraClip. It can happen with Pascal. It's been reported and it's been seen. So if you've gotten significant chordal entrapment, first attempt to undo gently the maneuvers that got you there. You know how you got there. Try to go in reverse. Use your muscle memory to try to get you out of it. Cycle the clip arms open and close and gently move back and forth without excessive tension. However, there will become a time when reasonable maneuvers have failed, and sometimes better to just deploy in place rather than risk damaging the valve. So find a position on a reasonable amount of tissue with good grasp so the clip will not embolize. All right. Once you've done that, we can now go on to the next major topic, single leaflet detachment. All right. So that's a beautiful, I hope that'll play because that sort of tells the story. Okay. So these are all supposed to be dancing. They're not playing for some reason here, but this is a single leaflet detachment on the septal side. And it's a dread complication. It's the major complication, device-related complication we see with TEER. And there can be 2 types. You can be partial
which is loss of leaflet insertion. You get a chordal grasp, everything looks fine. You release the clip and it bends. You lose leaflet insertion and you've got a big jet and the clip hasn't done anything. Or you can have a full single leaflet attachment when the clip is attached only to a single leaflet. So again, as I used to say in the Catholic schools, you need to avoid the occasion of sin. All right. How do you mitigate the risk of SLDA? You need to choose your appropriate size clip based on leaflet length, ensure appropriate grasping angles. We talked about that. Consider the use of 3D ice with X-plane to adequately visualize leaflets during grasping. Guggen showed beautiful examples of you could see clear as day the leaflets coming in, and ensure sufficient tissue in the clip prior to release and regrasp or use leaflet optimization as required. Do not let it go if you are not sure. If you do have an SLDA, if you didn't listen to Dr. Price or Dr. Singer, you just got unlucky. You have to critically appraise what happened. Insanity is defined as doing the same thing over and over again and expecting this different result. So don't just go put another clip on in the same manner and get a second SLDA. So why? Is it a leaflet problem? Large gap, tethered leaflet, or tissue quality, or is it an imaging problem? You just can't see the insertion well enough. And what are your options for mitigation? Can you do a repeat TEER? Can you do TMVR? Can you do management? So the first thing is improve your imaging. And again, as Jason kind of had me tip my hand earlier, ice is going to be your friend. Ice, ice, baby. I have had such good results seeing leaflets going into clips that I have ported over completely our practice to using this routinely. You can see leaflet insertion. You can see the grafts, the grippers falling. A lot of our patients have leads. They have mitral valve. They have TAVR. And this is just revolutionized. I apologize. I don't know why these aren't playing. They played right up until I started my talk. So confirming insertion is critical to avoiding SLDA. And it's especially helpful on multiple clips because the first clip also will shadow the second clip. So with the second clip, you can isolate that clip with ice. You can see the leaflets going in. You can make sure you have adequate grasp and you feel confident letting it go. Because very often the SLDA is the second clip, not the first one. Basic technical approach. Jason was nice enough to loan me these slides and then pointed out that maybe he borrowed them from Guggen. So we're not really sure the provenance of these, but two great minds have worked together on this. And I just stole them. So you have to have a strategy. If your SLDA was in the interseptal commissure, you want to go broader out where there's more leaflet, perhaps less tethering, better tissue quality. So your first clip, the red one didn't go, 2 and 3 should work. On the other hand, if you tried to be mid commissure, you tried to go out a little bit further and you didn't attach, bracket it, just like we would in mitral. Get one on either side and then stabilize them. Have a strategy. That strategy may end up being more of a European approach. Your first clip is good. Your second clip is you tried to bring in that center coaptation gap and you missed. So maybe you want to go posterior septal. Maybe you want to go anteroposterior and try to reduce that. And these can be effective strategies. When a repeat clip is problematic, all right, this was a referral from an outside hospital. And you can notice that this was ambitious at best. This was an off-label TEER prior to approval. It had immediate detachment, massive coap gap. There's a prior pacer lead. There's severe residual TR. The patient, unfortunately, had incapacitating heart failure. This did not look like a good clip case for us. You can see in these are playing. Okay, in this MPR, you can see the lead. You can see the clip floating in the breeze. So you have other options, right? So what we did was we brought this patient in and we performed, it'd be nice if these aren't going to play either. We performed a transcatheter tricuspid valve replacement. You can see the lead in the clip. Actually, the still pictures are pretty helpful. You can see the lead and the clip together in the center portion. They were nicely excluded. This stabilized the clip. The clip was fine, and we had 0 residual TR for this patient afterwards, as you would see on these beautiful non-running echo images. I don't know what's going on. They played before. So in conclusion, TEER is a safe procedure. The mortality rates are exceedingly low. The stroke rates are exceedingly low. The major device-related complication is SLDA. The rates of SDL are falling over time. Patient selection and intraprocedural imaging are the key component to reduce complications. Treating SDLA is dependent on a mechanism of failure, and you have options. You can repeat another clip in a strategy that you devise. You can look for another tricuspid strategy. You can pursue medical therapy. And there's much more on the complications in the ebook chapter. So I strongly urge you to go back to that ebook. And so that's what I had on complications. So thank you.
That's great. I feel like I need to go to confession now after hearing your talk on the occasion of sin, but
it's a thing.
That was fantastic. I mean, we definitely see some themes emerging here in all the different speakers that being very meticulous in your alignment and your pre-grasp kind of sequence is going to be critical for preventing complications. So preventing complications is always the best way to keep out of them. I think you showed some very nice approaches to managing SLDA, and you're right. I mean, the worst thing you can do, I think, in the tricuspid is to immediately rush in, with another clip and have a second SLDA. You really need to stop and think about, what you want to do next, and maybe even take the patient off the table and come back a different day. So what do you think, Anita? For time, should we
Yeah, maybe we'll go
maybe
back to
wrap up at
Ty. Yeah.
Dr.
Sure, I'll
Pham,
wrap
tell us
up.
how you resolved this challenging case.
Absolutely. Let me just share my slides again. All right, can you guys see that?
Yes.
Yes.
All right, perfect. So these were kind of the questions that I left you all with. And as many of you would expect, we end up admitting the patient for prehab. So she ends up on our heart failure service. We started her on a fixed dose INO dilator and Lasix 80 IV twice a day. And over the next 5 days, we're actually able to remove over 10 liters. And we repeated an echo. You can see it on the right-hand side there in the inflow view, where there's significant reduction in her gaps, much more improved than previous. And here it is with color, with resultant reduction in TR as well, although still significant. And gaps measured to be about 2 to 3 millimeters compared to the 11 or 12 from prior. So then we bring her down to the lab 2 days later for a definitive tri-clip. And here is the mid-esophageal X-plane with and without color. You can see there's a significant reduction in the coaptation gaps, as well as the residual TR. And here is the 3D MPR. And as you all mentioned earlier, there was an RV lead in the screening transthoracic echo. There was some question as to whether that was contributing to the TR or whether that was an instant bystander. Fortunately, here in the transgastric view, you can kind of see it's nicely tucked away along the posterior and septal commissure. And really, the remaining pathology is mainly central as well as along the anterior septal lead. And here it is with color. So we ended up proceeding with an XTW strategy. You can see the clip coming down here. We were initially targeting, or we actually decided to target mid and commissural anterior septal. And most of our grasping is usually transgastric, as Dr. Singh mentioned. But in this particular case, we had some really good mid-esophageal and deep esophageal windows. And so you can kind of see here on the right-hand side, the leaflets falling really nicely into the V of the clip. And this is after delivery of the first XTW with the elimination of the medial and lateral jets, and really the only residual jet was more central. So then we decided to bring another XTW clip down, and this is after delivery of that clip and really resultant 1+ to trace TR. So then at 30-day follow-up, we bring her back in and she gets a repeat echo. And just a reminder for those, it seemed like it was about an hour ago when you saw these initial images. On the left-hand side was when we first evaluated her with these massive coaptation gaps. On the right-hand side was the echo images at 30 days with demonstrating really stable clip position as well as durable reduction of the TR to really still around 1 to trace. And ultimately, she ends up with class 1 to 2 heart failure symptoms. Her creatinine remained stable, and there was no real change in her diuretic dose over the past 30 days. And she's not had any further heart failure hospitalizations. So to conclude, this case really illustrates the importance of prehabilitation. Especially for patients with very large coaptation gaps. And the screening right heart cath is essential, and it really helps to dictate really how intense and how long you should be prehabbing a patient. Whether you're planning to bring them in 3 days prior, 5 days prior, or even a week before the procedure. And then lastly, what often gets forgotten is that we would recommend discharging patients on the same high-dose oral diuretic therapy on discharge, and you can certainly adjust that or decrease it on follow-up if needed. But overall, we would keep that dose the same when we discharge them. All right.
Great, thank you.
Yeah,
And I think that's a really great final point with me talking about medical management. We didn't talk a lot about medical management, but it was a beautiful illustration of how the right heart cath should guide our therapy and preparing these patients for intervention. And often patients think that if we do this procedure, we can stop all their diuretics after. And it's usually not the case. I think that's a great take-home message. Jason, any other sort of take-home messages? We're a little over time, but just to sort of sum it up.
Yeah, I think it's very important with the gaps that the patient be probably admitted. I mean, prehab can be outpatient. It can start outpatient with increasing diuretics, but to really, I think, get to that final push to decrease the gaps, patients often have to be admitted at least for a day or two. So yeah, really great points, everyone. Yeah, so I guess we're at time, and we want to thank on behalf of SCAI and Abbott and the TEER ebook, all of the speakers and our friends that are on the call today, and all the attendees. If there's any questions, please don't hesitate to reach out to any of us. I think our emails are available in the TEER ebook, and very good.
All right. Thanks, everyone.
Thank you.